Ya. Bueno, lo que me contaste, porque voy a activarme. Seguíamos.
Gracias. Estamos muy contentos de tener esta tremenda audiencia aquí en vivo, de reencontrar caras que no habíamos visto hace varios meses o semanas. Solo esta primera parte va a ser en castellano para darle la palabra a Paula, que es la anfitriona de nuestro invitado. Gracias, Paula.
Gracias. Sí, la verdad es que le queríamos agradecer mucho. I would like to thank especially Dr. Asma Sanchez and Professor Felipe Fregni, who came here from Harvard, from the United States, to meet you all. So we have a mixture. I was telling Professor Fregni, we have a mixture from clinicians from Clínica Alemana and also researchers from the university. So this is probably one of the first times that we have this collaboration between the two universities in the same room, and that's quite interesting. So I would like to take a few minutes to present both of them, and I have my small screen. So Dr. Alma Sanchez, she's the program director of this program that is called PPCR, Principles and Practice of Clinical Research, that is run online for the last probably nearly 15 years. With different sites in different parts of the world. And she's an experienced associate director of education with demonstrated history of working in the higher education industry. And Professor Felipe Fregni, he's professor of epidemiology at Harvard University and associate professor as well of physical medicine and rehabilitation. It is a large clinical research laboratory that's called the Spaulding Neuromodulation Center that is funded by major NIH grants that are currently investigating techniques to guide and measure neuroplasticity. That is the focus of the presentation today. And he's directing the course. And I know most of you already know him, others don't. It's the first time. But it's great to see how motivated are all the students, but also all the alumni after the course. So thank you very much for being here, and we are waiting for this.
Sure. Thank you very much. Wonderful to see our colleagues from PPCR. So, and thanks so much for the invitation. We had a wonderful meeting. So, I think one thing that I'll start telling that in our meetings as well. So we have the so for those who are not aware of the program, there's a program offered by Harvard, and it's on clinical research methodology, and we study this collaboration with Clinical Alemana University. Spanish. So and we see the amount of changes as well. So most of the this program are clinicians, and how much after learning more about clinical research methodology, they become more passionate about that and to use it. And for me, it's the same thing as well. So my trajectory. So I did my training in Brazil, University of São Paulo, my medical training, my business, my PhD, which was 20 years. And I see as well. So I think that's it's after you plant a seed of clinical research methodology and learn more about research, it changes as well the mindset of the clinician. It is very important, of course, the work of the clinician, but also having this mindset and think a bit more about the evidence, about the critical thinking, about what you're reading. So that makes a big difference as well, not only to scientists but also for clinicians. And that's what we've been seeing. And we've been seeing this collaboration has been actually wonderful. I think more than 40 people have been trained here in the system. I think we can show one more. That's our goal. And what I'm going to talk, so, and again, I have this program, this educational program, each from Harvard. I also have my research laboratory. It's at Spalding and also in general. So what we're interested there is to understand how we can understand brain plasticity and how we can use that to change therapies for people with brain lesions. So that's what it's our goal in the laboratory. I guess that not many here may be on the neuroscience field, so I'll try to make it as more general as an example of how to use it, something that you find in the laboratory and you try to apply in the clinical practice. I think that's the goal here. So we can think that's, you can do research in different ways. And I think that's one example here to be a sort of a more, basic in terms of understanding the physiology, understanding what's happening, and applying clinical practice. That's not the only way to do research. Yeah, as a clinician, you can also collect data from patients and try to understand what's happening with that data. But that's one example, and I think that hopefully you get you to think a bit more as well about what we do there and so on. So was working too well.
You need to play.
That's fine. I can use this one. I can use this one.
How about that?
Oh yes, there you go. Yeah, perfect. So that's the first thing that I wanted to discuss, this idea of bench to bedside. And this has been used as well, so there's not good definition what that means, bench to bedside. Again, the word says everything, so bench, but it's sort of the on basic laboratory, so you have your bench there when you do your biochemical and chemical, whatever sort of experiments. And then, but one thing that's important is translating the knowledge to clinical practice, which is not easy. So one thing, so if you apply for a grant in US for NIH, you have several criteria. So the three main criteria is the significance, why that's important, and what is the impact of this research. And I think that's an important thing. So from bench, how you can apply to bedside. So that's a significance of, and of course, innovation and how you design this study. But I think again, knowing how to apply and doing that, it's not easy. And what are some examples you think on bench to bedside? Okay, you have the main one is biomarker. So what's a biomarker? So when you look to some sort of a blood marker or a physiological process, as I'll show here, anything you're collecting objectively, not how the patient feels, but you're collecting some sort of a data on one organ, for instance, and how we can use that to understand the disease and how we can use that to understand the treatment the patients are undergoing. And this is important because again, you think of development of that's what we're interested. So why we're doing clinical research and why we have so much money for clinical research, because we wanted to provide better treatments for patients. But if you only, let's say you find something, you go and find some new drug, could be a botanical drug. You wanted you do a clinical trial to test. Is that drug, the new drug that I found, better than placebo? You want a clinical trial and find that's better. But then the next question is, how does that work? And that's a very important question. Because if you don't know how the drug is working, then can you use it? You can still use it if you know it's safe and is effective, but it's still, so you don't know which patients respond better. You don't know whether you can use it in a different way. Whether also the results of your study maybe was just a random, could be a bias as well that you have in studies and so on. So understanding the mechanism is very important, and that's how this translational research helps us. So, and again, you can do different ways, and one way is looking for markers. Okay? And markers is, when you go to a physician, you have something. What do they ask at the end of, you talk to the physician, and at the end, what they ask of you? So they ask for some exams. Those exams, they came from some of the translational research, exams that are asked there. And that's exactly what we've been doing in the lab, but here in the brain, you can collect a blood marker for understanding the brain. So our marker in the brain is trying to understand physiology, neurophysiology of the brain. And a very interesting tool, it's called transcranial magnetic stimulation. What is that? So very, very simple idea. The idea is that if you deliver electrical current to your brain and measure the results of that, you can understand how your brain is working. So that's what it does. And you can say, why not just put an electrode and inject electrical current in your brain directly? The issue, if you do that, you need to have what the skull. The skull does not allow, it actually allows, but you need a high intensity current in order to pass the skull. The skull has a high resistance. So if you do a magnetic field passes through the skull and it goes to the cortex. If you do MRI, that's the same principle of MRI. So MRI, what it does, it sends the magnetic fields, and it causes some perturbation, and it detects how it changes. So that's what the principle of this is. Instead of using MRI that you have a diffuse magnetic field, you concentrate everything on this small coil. You see it over here. Okay. By doing that, you feel this electrical current focus in a small area in your brain, and you then induce an electrical current there. If you do that in monocortex, what happens? You put your coil in the monocortex. You use what? A movement, and you can capture that with a EMG, and you can capture that electrical current going there. So that's what this is pointed. Like this. So you do it in the motor cortex here. You can measure in the hand. The hand actually twitches. And why we use that? Because with that information, we know what? We know the amount of excitation and amount of inhibition of the cortical areas. Okay? And exactly that's what we do here, and you can see it in a little bit better here. So again, in magnetic field, so you have a coil. A coil just basically is a bunch of wire in a plastic sort of a case, you see. And the current passes here, this coil. When the current passes, remember the principle that you learned in high school. If the current passes very quickly, you have a high variation of current. It changes quickly from 0 to whatever the peak it is. It causes what? A magnetic field. Variations of electrical current cause a magnetic field. That's why you have these big wire cables on the street. You should be careful. Especially when very large. Anyway, so they cause a magnetic field. This magnetic field goes to the brain, and if it is a variety magnetic field, it causes what? Electrical current. So this is here, more electrical current in a painless manner. So it's very interesting because for the first time, I don't think that many people realize that, but for the first time you can induce electrical current in the brain in a painless mode. Before, what was the other method? Is you just put electrodes directly. That's how we do it in electrical convulsive therapy. And actually, it does exist sort of the some groups, especially there was a group in SMB, she moved then to NIH after that, but she was trying to do, using TMS, to do a magnetic seizure therapy. So basically using this for inducing seizures, but that's for treatment. That you in our experiments, we don't want to induce seizures, the opposite. So anyway, so basically again, we are inducing electrical current here, and it goes to the motor cortex, induce an action potential, and if you do that in the motor cortex, it travels through the cortical spinal tract and to your hand, and then you have a movement, and you can detect that. I think that's the figure here. You can detect that, and that's the famous MEP, motor evoked potential. This is just again the electrical sort of a discharge that you have it in your muscle to your muscle, and then you have it this MEP, and you can measure here this amplitude. You can measure the peak to peak amplitude, and that gives a number. And again, why this is important? So why learning about the size of your evoked potential, motor evoked potential, is important? Because that has implications about your motor cortex excitability. And then that's the basic research in a way. So now, how can you use this basic research? And actually also show something else that is a little bit more complex that helps us. That is what is called, you use what I showed you, but you do a little bit twist. And the twist here is instead of using one pulse, you do two pulses, one after the other. See, so you can do one pulse only, and you measure the MEP. Okay. If you do two pulses, they're very close together. What happens when you do one pulse very close to the second pulse? We call the first pulse as conditioning, the second one as the test. What happens there? So every time, that's the interesting part of here. Every time you try to do something, you deliver a current to your brain also changes. So it changes the excitability, the local excitability. And that's the idea. So you do one pulse, that's a weak pulse, but it changes excitability. And you do the second one to measure how it changed it. You see? So that's the whole idea here. So in a way, this elegant way to understand how the system is perturbed, what happens with the system. Again, this is based on physiology, and according to the duration or the interval between these two pulses, it can lead to inhibition or facilitation. So I think that's for those who are not in the neuroscience, you have to think as well. So the way our brain works, you have 8 billion neurons, 80 to 100 billion neurons, and they're all sort of sending information. They're all active. If you do an EEG, it's activity throughout your brain. And what's happening there is that most of these signals, they get inhibited. That's why you can speak, you can listen, and you can have a conversation, you can pay attention to something. You're getting inhibited. And that is an example as well. When you do a weak pulse that is very close together, the brain inhibits that. Because once you focus on what's coming later. Okay? So that's what we call the intracortical inhibition. Okay? So again, physiologically, we can understand that. Now, what is the application of this intercortical inhibition to clinical practice? So Francisca is a speech and physical therapist. Speech. Yeah. Speech therapist. So can she apply intercortical inhibition in her clinic with her patients? I think that's the question. So again, that's the the bench to bedside. And so why inhibition is important? Again, that's I think that's one thing that I think it's important, why I'm pushing forward. I think the inhibition is also an index as well of a lot of things, and one of them is organization. So when you suffer an accident, what happens in your brain? So when you suffer an accident, and then you go and you do an EEG, and Paula knows that. So we see when the patient is in coma, we do an EEG, say this EEG shows disorganized activity. Okay? And what that means? It means that in order for us to focus on something, think on something, to connect knowledge, we need a high level of inhibition. When you see children development, most of the processes that are happening in their brain development is on inhibitory processes. And you have the pruning, you have all these sort of other phases, but it's on inhibition. So a number of conditions in neuropsychiatry shows a lack of inhibition. You need that in order to what? In order to get something meaningful in your brain. So in order to think something complex, to understand something complex, you need to inhibit. Sometimes you think it's about facilitation. No, it's about inhibiting the noise. So you heard about the concept signal to noise. So that's what we are trying to do it here, decreasing the noise in order to enhance the signal. And that's why I think it's very important for rehabilitation. I don't think many people are looking into that. Basically, I think we are the ones pushing this here, but I do think that we can understand more and can help more to guide some of these therapies. Because that's one problem. So in rehabilitation is most of the things that are done in clinic, they are not as much as basically done without too much guidance on what's happening, you see. So then when you see a patient, when Paula sees a patient, then it's difficult to guide some treatments that you are offering. Anyway, so that's, and then let me show some results, what we've been doing here, so how we can use that. That's not our results, I'll show next. But some examples here, so you see it, oh, I forgot to say something here, but I'll show that later. Another way, I don't want to go too much in neurophysiology, but another way to measure inhibition is this is what we call cortical silent period. You see, again, your brain cells are constantly firing at different frequencies. So now all your brain cells are firing, but you see here now there's a silent period. What's happening now? This is not a brain damage, anything else, but this is temporary. This happened because while it was firing, you have a movement, there's a pulse that causes inhibition after that, pulse. Anyway, this is another way to measure inhibitory processes. But basically what shows here, you see it, is smaller than it is, less inhibition you have it. And several studies have shown, for instance, schizophrenia, you have less inhibition there, measured by cortical silent period. And it's interesting, as worse are the patients and medicated versus control, less inhibition you have it, less capacity to organize you have it. OCG is the same thing as well over here, so you have less. So actually, I want to go too much in details not to overwhelm, and then so but basically here is more higher here, less inhibition because it's close to the one, it's close to the test pulse. Okay. Anyway, so a few projects. Actually, this is an interesting project funded by FAPESP. That's the one type of collaboration we did in Brazil. So again, my laboratory there is in Boston, but I work in collaboration with several colleagues in Brazil. One of them is São Paulo, and this is the idea of this grant is called São Paulo Excellence Chair. Is a collaboration, international collaboration, and that's how we created this large cohort in rehabilitation with 500 subjects, which that's one thing that we discuss here that could be very interesting project for a number of clinicians. Anyway, so we collected this data set and collect a number of neurophysiological markers, including this inhibition one, the cortical inhibition, and cortical silent period, as I showed you. So here then goes to the bench to bedside, and so what happens here? Okay. Not to be I've done sometimes. So what happened here? So patients with more inhibition. If you guess, so you have patients with osteoarthritis. Okay? So how would you guess if you have patients in the clinic? Okay? Would you guess that these patients doing better, they would have more or less inhibition? Patients doing better, less pain. They doing better, less pain. They have more inhibition. Yes, yes. But the interesting part, and I think that's the most interesting result that we have it here. So the patients were younger, meaning that we're younger, the brain can have more sort of capacity to do more inhibition. They have less pain in the max scale, but I think that was the most interesting finding here. They had greater cartilage destruction. You see? Meaning that they were able to compensate for the cartilage destruction they had in their knee. So despite of having the knee, some of these patients, they have actually the most severe cartilage destruction. What happens is that the brain compensates for that. So I think for us, actually, that was a great finding, because in the end of the day, it's not only the level of destruction is how it interacts with your brain. So if you have a brain, and that actually can shift the treatments from the knee to the brain. Of course, you still want to do things on the knee, but it can shift as well to your brain. So it could delay as well the knee replacement. And I was talking to a colleague as well. It seems again the level of the numbers as well, but the percentage of the knee replaced. I don't know if there's anyone in orthopedics here. No? Okay, so I'll give us, but and remember, so you do replacement, you have to keep doing it every sort of 10, 15 years. So, and of course, all the costs, etc. So, can we, in patients with this cartilage degeneration, can we do something in the brain? And so these patients can live better and avoid some of these procedures. I think that's what, again, an example here. But if you're a clinician there, you see a patient with osteoarthritis, and you see, look, the brain, they have low levels of inhibition, so maybe I can start there. Again, that's how we translate to that site. And you should do something here.
I think in 2 you're switching screens, we can see.
Oh, the arrow. Oh, perfect. So then, and then actually that was a trial we did it exactly looking into that. So if that's true, so how you can enhance inhibition? So what can you do to enhance inhibition? So if you think on your, again, and here we're looking for the motor cortex. And of course, it's not only the motor cortex, but we are looking at the motor cortex. So that's one limitation technique. You have to look for these sort of motor cortex. And what we saw before, and actually you see in the other results we did, these patients with phantom limb pain, they have what? Low levels of inhibition of this marker here. So how can we increase the levels of inhibition? That's the interesting thing that we find in these studies. You can increase inhibition directly. If you want to increase inhibition, you have to use something else. You have to first stimulate that area. So as you enhance excitation, it enhances inhibition. It's quite interesting. So these ideas. So in order to again enhance the level of organization, you need to induce activity, and induces your brain reacts to that, okay? Almost increasing the resilience of that area. And it's quite interesting because phantom limb pain, remember, phantom limb pain is limb amputation. You have limb amputation and you have phantom pain. Why do you have phantom pain? because you are cutting some of the sensory afferents. You cut sensory afferents, what happens in the brain? Something is missing, and you lose that excitation of the sensory. Your sensory system is sending information all the time. So now your sensory system is sending information how you're seated and so on. And when you lose that, the brain starts going down inhibition. So everything starts shutting off. So how to replace that? Can you replace a nerve here? No. So then I think our goal is, and we saw decreased ICI, and we wanted to target directly in this area over here. How? Using a technique of brain stimulation that's called TDCS. You can use TMS, I showed you, the magnetic one, but you can use the one that's very simple, it's inexpensive. It was interesting. So this technique here, it's called TDCS. It uses electrodes, uses more electrical current. And this was about 10, 15 years ago. So we published at the beginning of this investigation, we published a small letter to the British Journal of Psychiatry. Saying, look, this would be a great thing for with lack of resource, because it's cheap. It's much cheaper than depression, much cheaper than antidepressants. And there's some colleagues in Australia saying, oh, you can't just turn your patient's head in a car battery. They were a little bit upset. But then they start doing research this year. After that, now they are the ones who publish more. Anyway, science is interesting. But then, so we can do directly, and you can also in the motor cortex. How? You can do what you call this mirror movement. Remember the whole thing. If you have an amputation, you get a mirror, and then to the leg that's moving, and you put a mirror, and you see your leg that is amputated, put in front of that, and you think your leg that's amputated is moving as well. So that's the mirror therapy. So that's the idea of increasing somatosensory experience. And you can also do imagination. It's quite interesting. There's results on this study. The imagination actually showed better results than the mirror when we observe. But anyway, so that's the idea. So one is through directly stimulation, and the other was through visual, and also the imagery that goes to the motor cortex at the end of the day. So this sensory experience. So just to summarize here, and I'm looking at the time, I'm getting close to the end, but just to summarize over here, one thing that was happening was interesting here. So that when we compare the between groups here, versus one thing that we saw here first, the active TDCS. Let me start with this one. The active TDCS was the group that had the best effects. So in terms of reducing pain. Actually, the effect size was quite high, 1.36 increase in levels, which is quite high for these patients. But also, one thing that was interesting in science is always surprising. The mirror therapy actually had the worst results. The best one was what we call covert therapy, that they had to do imagination instead of looking at the mirror. It was quite interesting because they had a paper published in New England. I think the group will be publishing the mirror therapies got great results. But anyway, so we show that may not be the one. And actually after that, other groups also agree with us that that's also one thing. And I think I'm getting off track here a little bit, but also shows as a clinician, sometimes you read something that just wait for other trials, other results to confirm. And I'm not saying that the groups they did something wrong, but experiments need to be replicated, need to be that kind of part of the critical thinking as well of looking at experiments. But that's to show that again we learn about the ICI, how it presents, and we apply something to enhance it, and then improve as well the pain levels. Let me show one more, and we can start for questions. Yeah, so I'll show the last one. This was a collaboration with a group from Porto Alegre, actually, in Brazil. And I think I just want to show, basically this is also measuring the cortical inhibition here. And it was interesting that compare here, so higher is less inhibition, the way it's measured. And it shows as well, so chronic pain and also major depression higher than healthy. Again, and we had it as well, this is not, several experiments showing that the level of inhibition, there's a good relation between, here then things get a little bit complicated, I don't want to complicate to leave the main message. So it seems that there comes the interesting part of the brain. So something happens, and I'll try to summarize this now. Something happens that causes fibromyalgia, which fibromyalgia, more and more, I'm convinced that it may be related to small fiber neuropathy. So now more and more clinicians are getting that and showing fibromyalgia being that, meaning you have a small fiber lesions that decreases sensory afference for these patients' fibromyalgia. So you get this breakdown in sensory information. Okay, so less sensory information going to your sensory motor cortex. That changes plasticity, and then you start having more pain. You start having central sensitization. But then, after that, then we'll call this chronic pain. Chronic pain. But then, I think that's the second part of the story that we learned as well recently. The intensity of pain is not related by that. You don't want to make that confusing. So you first get the breakdown in sensory information. You start enhancing, it causes central sensitization, it causes chronic pain. But the level of pain, when you have chronic pain, you have pain of 1 or 10, then you depend on other circuits. And here comes to the emotional, affective circuits, the limbic system, and so on. So the intensity should be regulated by other circuits, because the intensity is not as much is not as much associated with the level of ICI. At least we are learning here. So how these circuits they work in integration here, in order to define if you have chronic pain or not, and the level of pain that you have it. And then you can use that again. And how we can use information, as I showed you, developing novel treatments. Now you may want to develop treatments to establish the sensory loss that was made. You may also combine with other interventions to target the emotional circuits and so on. So with that, that's how we are learning a few things there in the lab in Boston, and I'll just put a summary here. I have no other, but that'll be too much. Okay, so that's the conclusion of the things here. So again, what we learned so far, it does seem the motor cortex, and I just showed the story for chronic pain. We have also studies in stroke and Parkinson's disease, which is another very interesting story, but it seems to have a decrease in inhibitory drive. But the amount of pain, as I said, it seems to be related to another marker. And I think that's an interesting part of trying to put the pieces together to understand, you see? And then you can understand better what happens to the patient. Because what happens now in clinical practice, a patient comes with pain. Most of clinicians don't like these patients. Then you give a drug, you just give it, and so, oh, it's chronic, I can do a little bit for chronic pain, or if it's acute. But we don't know what's happening. We don't know what's happening, we don't know which circuit should be looking and should be preaching more. And again, I do think that, as I show with the knee study, as more as we can also try to make brain more resilient, these sort of therapies that actually will improve. Yesterday, Cecilia, she's not here, correct? Cecilia. Yes, it's either we work in the complementary medicine intervention. So I think that actually it's a great, and one of these grants actually is funded by this one, the funding is by the Rehabilitation Institute of NIH, but the other one, the fibromyalgia, is funded by the National Complementary Integrative Medicine at NIH, because that's exactly what we needed then to use these other therapies to make the brain more resilient, because it's exactly the opposite way. That's my last thing I'll say. So how we treat pain now? Exactly the wrong way. What we do it, we use analgesics to cut sensory processing, so to decrease opioids. Again, great for acute, but why? I'm not surprised. And that's the first slide that I showed the PCR, the opioid crisis, the opioid epidemic. The opioid epidemic was interesting. I put these two slides together when I was on the PCR. Opioid crisis, opioid epidemic. It killed 1 million people in the US. COVID also 1 million. So again, two are very important, but we did very little for the opioid crisis, and it's still heavy opioid prescriptions are. I go to emergency room in the US, and it is in Boston. This is not in a small city in the middle of nowhere. Not in Boston. You go there with anything, and they give you do something small thing in your dental thing, and they also give you high dose of opioid. Yeah, most of these patients will be fine, but some will start using, and then what opioid does, it blocks all these receptors, the sensory receptors, and it's causing. Basically, you're inducing a mode of chronic pain when you take all opioids. You're doing what it does when you get a limb amputation. So you're doing the opposite. So you need to make the brain more resilient for that, not cut. So again, opioid in some cases will be important, yes, of course, but it also showed that we are doing the opposite thing that we should be doing. With that said, everyone, so thank you very, very much. I hope that I encourage you to do more, and I show how interesting it could be with all your research. And thanks so much.
Thank you, Dr. Peña. That was a wonderful talk. Now we have time for some questions, so I'll open mic for the public. So don't let me ask some questions, but anyone, they're never shy. Maybe they're shy today. If you want to, you can ask in Spanish and we can help translate. But at any rate, I'll start with the host privilege and ask the first question. In the knee research, do you think that regulating that excitation inhibition in the pain, in the chronic pain associated with osteoarthritis, will lead, or is anyone studying how much more exercise or how much more muscle, exercise or work can get those patients done?
Sure. Yes. So we have it. We decided to do it because of this. We decided to do the exercise plus TDCS, so you combine both. We did in fibromyalgia, we didn't do in the knee osteoarthritis, but because we wanted to do treadmill for them, but you can do other types of exercise in a way. So I think then the exercise will have double benefit. One is muscle strengthening and the sort of peripheral effect, but even more, again, the central effects. And I have no doubts. And then that comes as well, one idea, we did that study with some colleagues in collaboration. That was the group in south of Brazil, in Porto Alegre. So the idea was, can you do that before you have pain as a preventive measure? So basically, can you do exercise and stimulation, and your brain will be more resilient? If you have a lesion, you have less pain. And it was quite interesting. So that was in an animal. We got a lot of stimulation, and then there was the lesion in the nerve. And we saw that if you prevent it before, it developed much less chronic pain. So the idea for increasing brain disease by doing that. And that comes the idea as well, so, which is still difficult to do it, changing behavior, but changing lifestyle and why exercise is important and so on. But any kind of
Thank you. Jose?
Thank you for a wonderful talk. I was wondering how conserved this lack of inhibition you see is. For example, let's say alcoholism, for the group that works here on alcoholism, and that's linked to inflammation in the brain, right? So do you think, if you see a similar pattern?
Sure. Yeah, no, alcoholism is it's very interesting. So we also had research collaboration as well. But it does seem so in the collaboration effect, it does cause directly actually. That comes the interesting part when you have an exogenous inhibition. So if you try to do something but exogenous, and then you try to inhibit here. So what happens is that will decrease the level of excitation and will decrease your endogenous inhibitory. So that's why it's interesting. So this chronic patients with chronic alcoholism, if you stop alcohol, then they have the delirium. Why? Because you lost your inhibitory endogenous drive, and that's why that's the thing. So they start drinking sometimes because some psychological issues and other issues, but they only make it much worse because then you lose your protection. And the protection is your level of inhibition, and it goes the vicious cycle. You lose more, you want to drink more, and you drink not only because of that, you drink for other psychological reasons. But that's why I think it is an interesting approach trying to measure as well.
Yes, please.
Thank you, Professor, for a great speech. Thank you. I wonder if you have information regarding pediatric population associated with autism, and if there is a decrease in inhibitory drive in those patients or during development something happened.
Yeah, we had when so my first laboratory in Boston was at Brett as well. Then before moving to East and then there was a group I worked with them. I was not the main scientist there on this project, but we did measure the level of inhibition in autism high functioning patients there, and we published that in current biology, showing as well these patients also same story as well. So they had a lower level of inhibitory drive. So, and I think that's what it shows autism. So it does seem that some brain areas they have this sort of lack of development, and that's what it causes some of the symptoms as well, the language, the motion, because they cannot. So anytime you lose this organization, you also lose the ability to connect areas, and that's a problem of autism. So in the brain with lack of connection, especially between some areas. So it does show, and it's still. There's some studies as well trying to use brain stimulation for patient with autism, but it's still going a little bit slower than. You should understand more of what causes that, but it's a typical cause of development issues that results in.
Yes. I think the last one.
So thank you for your talk. So I work with children with abdominal pain currently, and we don't have much bench information. Why? But the thing that works best with best evidence is hypnosis. And so I wonder if you have done any work with hypnosis or meditation, mindfulness, or something like that.
So the two groups actually that we work in collaboration with, we applied for a grant in NIH, and we need to resubmit it anyway. So that's the process of the grant there. And then there's a group in Belgium, Aurora. So she has actually, we're working with them with hypnosis, and we got good results, and also the group in South of Brazil also had good results with them as well. And again, the whole thing of hypnosis, so we should need to learn more about what, and there's a lot of misconceptions, by the way, about hypnosis. So, but basically, it is, I think you can think on change brain oscillations, inducing sort of this relaxation state, which is very different than a lot of people think about what hypnosis is, but which you can achieve that by mindfulness or by hypnosis. But when you do that, it's almost, you do a reset of the circuits. So, and including those inhibitory drives, because what happens there as well, so if you think on brain activity, so if you have circuits that have low inhibitory drive, low excitation drive, and these circuits you almost get, so think on the brain activity overall, and you have one area that is being less active, with less inhibitory drive. What you wanted to do, you wanted to reset everything and start reconnecting. So I think that's how I see the effects of hypnosis, which then it's difficult because everything that involves that, it requires a lot of sessions, which then becomes another problem as well. It's interesting for scientists to think, because there's another problem when you study this, in which scientists, they usually don't care that much, but it's important. So how to get someone to have it 30, 40 hypnotic sessions instead of, oh, I want to take a pill. That's much easier. So, and how to convince them that to do treatments like that require much more effort and time and commitment. So that's also another reason as well. But yeah, so I do think, and they have some studies as well showing exactly that increases your brain organization, increases number of functions as well as social functions. Great question.
Yes, please.
I was thinking about the model you presented, the same for migraines first, and I have a second question. What is your experience with deep magnetic stimulation? What does it feature?
Sure. So I think magnetic stimulation, it's the I'll simplify just to here now, but you can think of similar as the TDCS, meaning that you induce electrical currents in the brain. But if you want this, so again, I don't want to complicate it here, but when you do this measurement, you do one pulse only. If you get your TMS, you do several pulses, they will call repetitive TMS, then you can start changing brain function. So that's the idea here when you do TMS. And you can do TMS in the monocortex. I think the reason with TDCS is that you can use TDCS combined with the exercise. TMS, you have to sit there, it's a big machine and a big pulse. You can't be running a treadmill. With TDCS, we put a TDCS and we have in the lab a treadmill there, and the patients walk on the treadmill with TDCS connected. You can do things at the same time. So, but yeah, so you could do TMS, or you can do, and I think that's one thing that's it's interesting as the importance of research here for the clinicians as well. So the clinicians, they are the ones who are with the patient, and as much as we think together, we can also develop treatments that would be meaningful for patients as well.
One last question.
I don't know if I understood correctly, but it seems to me that you're studying this inhibitory drive in the whole motor cortex, and maybe that will mean that you're studying like the average or close to the average of the neurons. Is there a need to be more specific to study neurons that are closer to the function that you're trying to? And would it be possible to be closer to that?
That's a very good question. Yes. Again, is there a limitation because when you are inducing electrical current, so I think that's so when you use the electrical current, so basically you have it, the peak of current in the brain is about 2 by 2 millimeters. So then you go here, you basically have a large area as well, and you get most of the interneural levels. The one thing that happens is that the magnetic field it decay with the square of distance, meaning that most, if you think this is right here, and so you get a current that gets most interneurally. So how specific is that? I agree with you, it's not as specific, but that's actually the best we can do it. You are not going to get a single circuit. You are not. That's one problem in neuroscience. So if you go to neuroimaging, I started talking about what, in the case of neuroimaging, will be here for a long time. But I think that even though you get a large area, there's one thing that's important. You are measuring functionally. When you measure in a muscle, over here your hand, and then you have an electrode here, you measure this muscle, you know you're measuring this specific area here. It is the FDI, of course, interdigital exhaustion. So you are measuring specifically this muscle. So you know at least it represents a specific circuit, even though you get several circuits involved, you get these. So I think the functional assessment, that's why I like the ICI, because you do measure specific muscle, and you do measure what happens one pulse interferes with the effects of the second pulse. But it's still, so the resolution of all techniques, imaging, EEG, TMS, they're still low, so they still need to be improved. So that's also one of the challenges as well for NIH had some sort of, it's called brain initiatives, trying to enhance the resolution of techniques. I don't think there's some ideas, but there's no major breakthrough in terms of understanding. So I think that's the beauty of science in a way as well. So you have to use limited information. You need to build this puzzle, right, to understand what's happening, which is difficult. I think that's one thing that's for people starting this field to learn and to improve over time as well. So in how to put these pieces together and understand what's happening. And sometimes we may go in the wrong direction and we learn and we go back. But at least again, I think that's so far what we see in different studies, it does show this should be something that is helping us to understand a bit more about. But at the end of the day, and my last comment is again, the brain is still, it's interesting, compare the brain to other organs. It's still a black box if you think it's not only the mechanical protection, but also to understand what's happening there. So you don't have zero markers. You don't have it even so the best you can get it is like to assess by electrical activity, which is EEG, TMS, or neuroimaging, which is also has a delayed response because you have electrical activity that changes the metabolism, and that's what functional MRI is getting, the oxyhemoglobin changes. So that's why it's so fascinating, the field of neuroscience. I know what other fields are fascinating. Thanks so much, everyone.
All right, thank you. Bueno, gracias a todos por venir y nos vemos la semana que viene en otro seminario académico de Facultad de Medicina y del ICI. Muchas gracias.
Los invitamos también a compartir acá afuera en un almuerzo sencillo, donde podamos seguir conversando.
La rúbrica también.